My name is Dr. Arif and I'm your tutor for today. On this channel, we simplify medical knowledge from surgery, medicine, ops, gynecology, obstetric, and related specialities so that learning medicine becomes easy and approachable for everyone. With that said, let's jump to today's session.
Learning objectives of today's session are drug interactions with anesthetic agents and pre-anesthetic medications. Underneath the drug interactions with anesthetic agents, we will learn about pharmacokinetic drug interactions with examples, pharmacodynamics drug interactions with examples, and dose response curve. And underneath the pre-anesthetic medications, we will learn about the medications which are used to relieve anxiety and produce sedation, produce analgesics, prevent bradycardia and decrease bronchial and salivary secretions, prevent nausea and vomiting, medicines which are used as muscle relaxants, and medications which are used to prevent infections. Drug interactions with anesthetic agents. Now let's have some basic knowledge. Drug interactions are of two types: pharmacokinetic drug interactions and pharmacodynamic drug interactions. In pharmacokinetic drug interactions occurs due to alteration of ADME. That is, A stands for absorption, D stands for distribution, M stands for metabolism, E stands for elimination, and C stands for clearance. Now, let's talk about some of the examples. How the absorption of the anesthetic agent is being altered. For example, when lidocaine is combined with epinephrine, epinephrine decreases systemic absorption of lidocaine by vasoconstriction locally. Epinephrine being catecholamines, it has vasoconstricting effect. How the distribution of the anesthetic agent is being altered. For example, when thiopentone, which is ultra short acting barbiturate, combined with valproate, which is anti-epileptic drug, then thiopentone, being lipid soluble, is albumin bound, and albumin in the plasma is the driver of the thiopentone. And valproate affects the liver and decreases protein synthesis, especially albumin. In this way, the concentration of free thiopentone increases in blood, and this leads to toxicity when it crosses blood-brain barrier. Second is metabolism, how the metabolism of the anesthetic agent is being altered. The definition of metabolism is biotransformation of drug to make drug water soluble so that it could be removed out of the body. For example, when midazolam, which is short-acting benzodiazepine, combined with erythromycin, which is macrolide. Erythromycin inhibits the cytochrome P3A4, which typically normally breaks down or metabolize or biotransform midazolam into water-soluble product. Since it inhibits the cytochrome P3A4, then there is toxicity of midazolam. Second example, when halothane, which is inhalational general anesthesia, combined with any of the cytochrome P450 inducing agent, means such agents which enhance the activity of cytochrome P450, for example, phenobarbital, phenytoin, rifampicin, so they increase metabolism of the halothane in the liver. As a result, there is increased production of trifluoroacetylated reactive metabolites, which leads to hepatotoxicity. And then how the elimination of the anesthetic agent is being altered. Before this, we should know a difference between elimination and clearance. Clearance means removing drug from plasma per unit time, while elimination means removing drug from the body. So if we talk about elimination of the anesthetic agent, so example of which, when lidocaine is combined with beta blocker, for example propranolol, it reduces the hepatic blood flow. How it reduces hepatic blood flow? By decreasing cardiac output. Means beta blocker causes bradycardia, due to which cardiac output decreases, and as a result of which hepatic blood flow is reduced, and this leads to reduced metabolism of a lidocaine. and then there will be lidocaine toxicity. Second is that morphine is eliminated or cleared from the body through kidney. If a patient is having renal failure or patient uses NSAIDs which affects the function of the kidney, then there will be morphine toxicity. So this was how the pharmacokinetic drug interactions work. Now let's jump to the pharmacodynamic drug interaction. It occurs due to alteration of mechanism of action of the drug, which can occur in three ways. Number one, additivity means the total effect which is produced is equal to sum of individual effects of the combined drug. For example, when propofol is combined with benzodiazepine like midazolam, it enhances the CNS depression. Synergism means when the total effect produced is more than the sum of total effects of the drugs which are being combined. For example, opioid like fentanyl is when combined with benzodiazepine, they have synergetic effect. And while antagonism means to inhibit the mechanism of action. For example, action of the opioid like fentanyl can be reversed with naloxone. Action of the benzodiazepines can be reversed with flumazenil. Action of local anesthetics like lidocaine can be reversed with lipid emulsion. And on the other hand, action of non-depolarizing muscle relaxant can be reversed with newstigmine or atropine. These were the examples of pharmacodynamic drug interactions. Now, for instance, if patient is taking hypertensive medications, now how the hypertensive medications interact with the anesthetic agents. If patient is taking beta blocker and calcium channel blocker, then there will be additive bradycardia and exaggerated hypotension when combined with propofol. Why? Because propofol causes hypotension by vasodilation. And when beta blocker or calcium channel blockers are combined with ketamine, it exaggerates the hypertension. But we have to continue beta blockers pre-operatively. Why? Because it leads to withdrawal symptoms if we stop the beta blocker earlier. So the withdrawal symptoms can be rebound hypertension and tachycardia, which ultimately leads to a myocardial infarction. So that's why beta blockers should be continued pre-operatively. Now, for instance, if the complications occur, if blood pressure rises during surgery, you have to administer intravenously glyceryl trinitrate. And if the blood pressure drops during surgery, then you have to give IV phenylephrine, which is alpha agonist. Second, if the hypertensive patient is using ACE inhibitor or ARBs, ACE means angiotensin converting enzyme inhibitor, ARBs means angiotensin receptor blockers, then there will be high risk of refractory hypotension during induction with general anesthesia. Well, I have witnessed this refractory hypotension which occurred in one of our patients. He had taken captopril, which is ACE inhibitor, before surgery without telling the doctor or staff. And when we induced induction, there was hypotension. So for this one, we injected phenylephrine. But phenylephrine was increasing blood pressure slightly, and then there was drastic fall in blood pressure again. Finally, we had to stop the surgery and we infused the patient. We ran the infusion of the phenylephrine combined with epinephrine. So this was how his blood pressure was maintained. So never take ACE inhibitor or ARBs before the surgery because it will create so much problem for the anesthetic. So you have to hold it on the morning of the surgery. Now, if hypertensive patient is taking alpha blocker, then it exaggerates hypotension during induction. However, it should be continued preoperatively. Now, if a patient is taking medicines or drugs for central nervous system, for example, if patient is taking sedatives or hypnotics, when it is combined with opioids, there will be CNS and respiratory depression. If patient takes antipsychotic drugs and combined with opioids, there will be marked sedation. If patient takes SSRI, means selective serotonin reuptake inhibitor, and is combined with opioid, especially meperidine, this causes serotonin syndrome. And when monoamine oxidase inhibitors are combined with opioids, this leads to hyperpyrexia coma. So before jumping to the dose response curve, there are some basic terms you should know about. One is affinity. Affinity means how strongly a drug binds to its receptor. Potency is defined as amount of drug needed to elicit an effect. And always remember, dose and potency are having inversely proportional. Means if a drug is highly potent, then there will be need of low dose of that drug to produce effect. If the drug is has low potency, then there will be need of high dose of drug to produce effect. Efficacy means maximum effect produced, that is called efficacy, and maximum effect is shown as Emax. Now, dose response curve. Along the x-axis we are having increasing dose, and along y-axis we have increasing effect. As you see at this point, not enough drug receptor complexes to elicit effect. As we increase the effect, as we increase the dose, but there is no increase in the effect. Why? Because there is not enough drug receptor complexes. Then, as there is increasing of the dose, there is gradual increase in the effects as well. So, drug receptor complexes gradually increases, and this effect is also gradually increases, and this is called graded dose response relationship. Now, to a point comes when you increase the dose, there is no increase in the effect. Why? All receptors are occupied and maximum effect is produced, and this is called efficacy or Emax. Now, 50% of the Emax, 50% of the maximum effect is called EC50. And EC50 is inversely proportional to potency. A drug which is highly potent will have low EC50, and a drug which has low potency will have high EC50. It means if a smaller dose of the drug produces 50% of Emax, then the drug is highly potent. Now, ED50 means amount of drug needed to produce effect in 50% of population. This was EC50. It is ED50. ED50 means amount of drug which is needed to produce 50% produce effect in 50% of population, and this ED50 is also called median effect dose. And there is another important thing that you should know, because in coming lectures we will need this knowledge, so that we have to understand the big chunks of the knowledge. MEC, minimum alveolar anesthetic concentration. This is how we measure the potency of inhalational general anesthesia. So potency of inhalational general anesthesia is defined by MEC. It is ED50, means amount of drug needed to produce effect in 50% of population. MEC is small for potent agent, means low dose is required, like halothane. And MEC is large for less potent agent, means large amount, large dose or continuous dose of the drug is needed. Example is nitrous oxide. We will talk about these in detail with their practical application. Now, time comes for pre-anesthetic medications. Now, why do we use pre-anesthetic medications? It means that before anesthesia, we use group of medicines. The aim of those medications are to relieve anxiety and produce sedation, or produce analgesics, or prevent bradycardia and decrease bronchial and salivary secretion, or prevent allergic reactions, or prevent nausea and vomiting. or muscles use or medications used as muscle relaxants or antibiotics used to prevent infection. So these are the aims of using pre-anesthetic medication. Now let's first jump to medicines or medications which are used to relieve anxiety and produce sedation. It is benzodiazepines, for example, diazepam, temazepam, midazolam. We will talk about these drugs and this group of drugs in detail in our pharmacology lectures. Mechanism of action of benzodiazepine is that it binds to busy site of GABA A receptor along with GABA. GABA is neurotransmitter and it is inhibitory neurotransmitter. It stands for gamma aminobutyric acid. Now GABA A receptors are ligand gated chloride channel. These drugs increase frequency of ligand gated chloride channel. So that's why this acts as a muscle depressant, a CNS depressant. Now, what are the adverse effects of the benzodiazepine? Mnemonic is 8 part. A stands for anterograde amnesia. D stands for drowsiness, decreased concentration, decreased problem solving abilities, decreased reaction time. That's why when benzodiazepine is given to any patient, he is asked not to drive, right? And P stands for paradoxical stimulation in certain parts of the brain, which leads to agitation, anxiety, restlessness. Ataxia means A stands for ataxia. Ataxia in elderly means there is that coordination between muscles are lost and there's high risk of fall in elderly patient. R stands for respiratory depression and coma. T stands for tolerance, means once you use it, multiple utilization of these drugs decreases its effect, so that's why you need to use a higher dose so that you have to achieve desired effect. Now, medicines which are used to produce analgesics. Analgesia means relief pain, means pain free. For example, morphine, fentanyl, meperidine, and they are strong mu agonists. But you can also use partial mu agonists like nalbuphine and toradol. Now, medicines which are used to prevent bradycardia or decrease bronchial and salivary secretions like atropine, glycopyrrolate, and scopolamine. The side effects of them are tachycardia, palpitation, arrhythmias, hypotension, dryness of mouth, constipation, and urinary retention. Now, drugs which are used to prevent allergic reaction. Antihistamines are having two generations. Generation 1 includes chlorpheniramine, diphenhydramine, doxylamine, hydroxyzine, promethazine, dimenhydrinate, doxepine, meclizine, scopolamine, chlorcyclizine, mepyramine, tetrahydroxycarboline. And second generation includes acrivestine, cetirizine, levocetirizine, loratadine, disloratadine, fexofenadine, esomeprazole, ceftriaxone, terfenadine, ketotifen, and cyclizine. So these are two generations of antihistamines which are used to prevent allergic reaction. Now their side effects: anticholinergic effect, like patient will be hot as a hair. Patient have dry mucosa and dry skin due to inhibition of sweat glands. Mnemonic is dry as a bone. Due to vasodilation, there is redness of the face and body. This is red as a beet. Blind because of mydriasis means dilatation of pupil. There will be blurred vision. Blind as a bat. Mad that the patient is confused, agitated, and there is impaired memory. So that is mad as a hatter. And there is urinary retention. So you can remember is as full as a flask. So these are the mnemonics, or this is how you can remember the anticholinergic effects of the antihistamines. Then anti-alpha adrenergic effect. It can be remembered by alpha. A means asthenia, means patient feels weak or there is easy fatigability, lightheadedness, postural hypotension when patient is in lying position, and when he stands up, there is drop in blood pressure, decreased blood flow to the brain, and patient may have syncope. headache, and accidental syncope. So you can remember it with these image, and it will be helpful for you to remember it for a longer time. Then there are some CNS effect of the antihistamines, like it decrease appetite, it decrease psychomotor and cognitive functions. Now there are a group of medicines which are used to prevent nausea and vomiting. But first, why nausea and vomiting is caused? Nausea and vomiting can be caused by volatile anesthetic agents, by opioids, nitrous oxide, or patient is having hypotension, or neostigmine is given greater than 2.5 milligram, or there is post-operative pain, or there is history of motion sickness, or type of surgery also affect this. Means ENT, screen surgery, gynecological, and head and neck surgery. Patient undergoing these surgeries will be having high probability of having nausea and vomiting, or there is prolonged anesthesia, like in case of plastic surgery. So you can give serotonin antagonist like 5-HT3 blocker. Example is ondansetron, granisetron, tropisetron, alosetron, and dolasetron. Some specific use of these serotonin antagonists. For example, antagonist is used to prevent nausea and vomiting associated with surgery and chemotherapy, but its side effect is prolongation of QT interval. On the other hand, alosetron is used only for women with severe diarrhea, predominant irritable bowel syndrome, and its side effect is ischemic colitis. You can use prokinetic agent like metoclopramide, or you can use steroid as an antiemetic, but its mechanism of action is unknown. However, IV dexamethasone is used as antiemetic. Now, muscle relaxant. There are two types of muscle relaxants. One is depolarizing or non-competitive muscle relaxants, and the other one is non-depolarizing or competitive muscle relaxant. The depolarizing or non-competitive muscle relaxant includes succinylcholine, which is also called succinylcholine. It is the most rapid acting of all muscle relaxants, and therefore it is used as a rapid sequence induction. We will learn about this in our next lecture. Now, depolarizing muscle relaxant means succinylcholine is having two phases. In phase number one, there is persistent depolarization leading to transient fasciculation, and depolarization increases if the cholinesterase inhibitor is given. In phase 2, persistent depolarization, which occurred in phase 1, leading to desensitization of acetylcholine receptors. Now membrane is repolarized, which cannot be depolarized again, and this repolarization is decreased if cholinesterase inhibitor is given. Side effect of the depolarizing or non-competitive agent is that the succinylcholine is metabolized by butyrylcholinesterase or pseudocholinesterase. So they are made by liver. So those who have deficiency of these enzymes, why they do have the deficiency of these enzymes, either by cancer, liver disease, exposure to insecticides, or malnutrition, then this leads to apnea or succinylcholine apnea. This is one side effect, important side effect of the succinylcholine. The second side effect is malignant hyperthermia. We will talk about this in detail when we study about inhalational general anesthesia. It causes hyperkalemia. That's why it is absolutely contraindicated in patients with burn, because in burn patients cells are damaged and intracellular potassium is being released. So normally, basically, they are having high level of potassium in their blood. It increases intraocular pressure, so it cannot be used in patients with glaucoma. It increases intragastric pressure, which leads to emesis, nausea and vomiting, and it causes myalgia, means generalized body ache. Now, non-depolarizing or competitive muscle relaxant. They are reversed by newstigmine or combining with atropine. Example of this is tubocurarine, mivacurium, and atracurium. They have slower onset of action but longer duration. Side effect includes that they release histamine, and this histamine leads to vasodilation, causing flashing, hypotension, reflex tachycardia. Due to histamine, there will be bronchospasm. That's why it cannot be used for asthmatic patient. Due to histamine, there is increased respiratory secretion. So you need to do vigorous actioning after anesthesia. So atracurium, it is histamine is released but good for kidney and liver failure. So you can use these in patient having kidney and liver disease. Vicuronium, less histamine is released, but it cannot be used for kidney or liver failure patient. Rocuronium, best for rapid intubation and excreted unchanged by bile and urine. Now, the last group of medicine we can give to patient is to prevent infection. To prevent infection before surgery, you give first generation cephalosporin like cefazolin at the dose of 1 gram, or in case of resistance, you can give cefaperazine combining with beta lactamase inhibitor like sulbactam 2 gram, and you can give a combination of amoxicillin and clavulanic acid 1.2 gram. But if there is history of allergy to beta lactams, then you give clindamycin with gentamicin. They basically come in same combination, or clindamycin with estronium. To cover anaerobic bacteria, you give metronidazole 500 mg IV, or you can give metronidazole oral, which is 400 milligram. So thank you for watching. If you find this content helpful, please don't forget to hit the like button and subscribe to my channel for more in-depth educational videos. Share this video with anyone who might benefit from it, and feel free to leave your thoughts or questions in the comments below. I love hearing from you. And also, if you are looking for more detailed notes and resources to enhance your learning, head over to my Udemy page to download my comprehensive notes, and they will help you dive deeper into the topic and make your studies even more effective. Stay motivated, keep learning, and I will see you in the next video.